All right, we are at 10 a.m. and so why don't we get started? Zeke, you are now unmuted.
Dangerous.
Welcome to another virtual session of The World Today, hosted by Perry Worldhouse, the University of Pennsylvania's Hub for Global Engagement. I'm Michael Horowitz, the interim director of Perry Worldhouse and a political science professor at the University of Pennsylvania. I hope everyone joining us for this event is safe and healthy as the coronavirus continues its run around the world. We are delighted to be co-hosting this event with the German Marshall Fund of the United States, another step in a growing partnership between Perry Worldhouse and GMF. And so I want to give Karen Donfried, the president of the German Marshall Fund of the United States, a moment to introduce herself before I introduce our speaker and lay out the ground rules.
Thanks so much, Mike. It is always a delight to cooperate with Perry Worldhouse, so thank you for this opportunity. And Dr. Emanuel, GMF focuses on strengthening transatlantic cooperation, and I can't think of a more important time to try to work closely together than in battling a common pandemic. So thank you for also sharing your expertise with our network, which extends on both sides of the Atlantic. So thanks.
Thank you.
Thank you, Karen. Now I want to lay out the ground rules for this event. Dr. Zeke Emanuel, our featured speaker, will kick us off with 5 to 10 minutes of remarks. Karen and I will then ask him a few questions before opening it up to questions from the audience. To ask a question, please use the Q&A button, which you can find on the bottom ribbon of the Zoom screen to submit a question. We'll review and select questions from that list. Also, feel free to do what you're already doing, which is discuss what's going on in the chat, and a reminder to keep it clean and safe for work. We would appreciate that. And without further ado, I want to introduce Dr. Zeke Emanuel. He is the Vice Provost for Global Initiatives and the Chair of the Department of Medical Ethics and Health Policy at the University of Pennsylvania. He was a top healthcare advisor during the Obama administration and the architect of the Affordable Care Act. He's one of the most important public health experts in the world, and he has been playing a critical role in shaping the global conversation about responding to the coronavirus pandemic. Thank you very much. I guess I'll call you Dr. Emanuel for joining us today. We're delighted to have you. The floor is yours.
Thank you, Michael. So I'm going to try to keep it simple. I'm going to say a few words about the coronavirus and some of what we know about it, a few thoughts about the therapeutics and the vaccine situation, and then talk about the wider economic impact, which is on everyone's mind, and hopefully we can keep that to 10 minutes. So, you know, everyone talks about it being novel. What's novel about this coronavirus is that no one has immunity to it. It's very easily spread, much more easily than assorted other coronaviruses we've seen in the last few years. You've heard about SARS and MERS, much more difficult to spread, much more difficult to it's much easier to spread than, say, Ebola, and it's even easier to spread than the regular influenza that circles the globe every year. It is not as deadly, which is why it's easier to spread. Those things go hand in hand. If it's too deadly, it's harder to spread those viruses. It mainly infects, not mainly, it infects the lungs. That's where it sits. But the damage seems to be much more diffuse. No one is exactly sure the process. It does seem to lead to ARDS, the acute respiratory distress syndrome, which blocks the lungs and prevents the diffusion of oxygen into the blood. That's the main problem. So you see a lot of patients who otherwise look healthy and can't oxygenate. Those are the people like Boris Johnson who end up in the intensive care unit and on a ventilator. But the cataclysmic event is almost never just the lungs. It turns out to be other things. There seems to be some diffuse, what we call DIC. It's a disseminated intravascular coagulation, that is clotting. So somehow this virus is inducing the immune system and the clotting factors to clot in small vessels. That is very hard to deal with. And there are, therefore, you know, the life cycle is it comes into the lungs, it reproduces in the lung cells, it then kills those lung cells, and it either invades other lung cells or gets spewed out, and the immune response happens to try to contain it. There are, I would say, 4 potential ways of devising therapeutics for this. One is to prevent the virus from entering the cells, blocking its entry at what's called the ACE2 receptor. Another is to block its reproduction, so block the enzymes that allow the genetic material to reproduce. Another is to block the protein enzymes that the virus has to have and use to cut up the proteins that it needs, like the special protein to get into the cell called the spike protein. And the third is to modulate the immune system so that the immune system responds well, but doesn't go into what we're seeing as this hyperimmune response. Those are really 4 places to go. Everyone knows now the names chloroquine and hydroxychloroquine, thanks to President Trump. It is certainly not going to be a magic bullet like penicillin. Just forget that idea. What it appears to do is to change the pH. It doesn't even block the receptor where the virus and the cell intersect. It seems to change the pH when the cell engulfs the virus to make it less effective. That is not a super strong antiviral effect. It's a pretty weak viral effect, which is why I think you keep hearing Tony Fauci being skeptical that this is going to be the magic bullet and that we need more data, because it's very unlikely that this is going to have a really big impact. Plus, if you were going to use it, you'd probably have to use it very early on, maybe even before people know they're infected. So a lot of skepticism is present there. A lot of people are trying off-the-shelf antivirals that affect those proteins or the reproductive enzymes of the virus. And those are, you might say, off-the-shelf is not tailored to this virus, so the potential effects are not that great. And we don't understand the hyperimmune response yet very well. And so it's a little unclear. Again, the last thing I'll say about this is many of the experts believe, well, let me say this. I'm an oncologist. When we fight cancer, typically we use multiple drugs because one isn't good enough. The cancer can evade. In HIV, we use multiple drugs, a 3-drug cocktail. To the extent that therapy is going to work, we're almost assuredly going to need multiple drugs. An antiviral, maybe 2 antivirals, an immune modulator. One thing is not going to work. This isn't like a bacteria. You give it penicillin or an equivalent modern antibiotic and you can get rid of it. So I think that's where we are on the therapeutics. The vaccines, we've got lots of people doing vaccines. There are 3 types of vaccines: an RNA vaccine, a DNA vaccine, and the standard that we've been using for decades, basically taking the virus, inactivating it, and then putting it in a vaccine so the body reacts to that inactive virus. Johnson & Johnson is doing the last one, a sort of inactive vaccine. They have huge production capacity, but I've talked to their senior officials, you know, maybe Q1, Q2 in 2021. So that's a year from now, it'll prove positive and they can produce enough for healthcare workers. And then maybe by Q3, Q4, they'll have up to 1 billion by the end of 2021 doses that they can distribute. But that's if everything goes well. We don't have a lot of coronavirus vaccines because it's a very hard virus to actually get vaccines on for a whole series of reasons. So don't think we're going to get a vaccine before next year. And I would say out to the public for general immunity, not till, you know, call it July, August, September timeframe. That's kind of the optimistic reading. And I think if you follow Tony Fauci pretty well.
July, August, September of 2020 or 2021?
2021. Did I say 2020? 2020.
No, yeah.
Yeah, 2021. So a year, 15 months, 18 months from now. If I were, and if you follow Tony Fauci well, you'll hear him constantly saying, we're going to really be able to get back to normalcy with a vaccine. And I think he's right. What we understand is normalcy: going out to restaurants, going out to bars, having sporting events, going to concerts, having religious services. 2021. And I think what I'm really frustrated by is the sort of White House approach. You know, we got to get back to normal. Easter, we got to have football season in September. All this, that isn't happening. That's just, you know, the 15-day plan then became the 30-day plan. At the 30-day plan, we'll just be at the peak, maybe slightly tilting over the peak in major places, but other cities will be rising. Indianapolis is now coming up. You're seeing rises in Pittsburgh. You are not going to be opening the economy at the end of April. And that is just, I mean, we have to prepare the country. This is an 18-month process. That doesn't mean we're in the current situation for 18 months. But if we do this shelter in place, we put in testing, we put in contact tracing with tech, which we have not done. I think tech has been singularly not actually that responsive in helping solve this problem. They've been trying lots of things, but I think they're so focused on tech, not focused on the public health needs that we need them to do. Then you can slowly open up. And I have suggested, but you know, just a suggestion, that we start with younger people, because they're not immune, but they don't seem to have severe side effects from this, probably because their immune system is in better balance, but we don't know. That's speculation. And so you could run much smaller risk by opening up with younger people. But of course, you just can't have, you know, 10 and 12-year-olds running around schools or camps or whatever. You need adult supervision, and those adults, you know, run a risk of being exposed and having bad things happen. And so I think, you know, we've got to figure out how we can do that better. We also have to figure out, and this I think is, I'm going to end with this so we can get to your more interesting questions. With one of the things that also frustrates me is, because we're all thinking, Washington is thinking short term, the solution so far, yes, we spent $2 trillion in the third bailout, but the solutions have all been what I call Band-Aids. It's not because we're not spending a lot of money, but it's because they're not thinking in the right way. They're thinking, you know, we'll give a few more weeks, 13 more weeks of unemployment. They're thinking we'll give forgivable loans to small businesses to keep people on their payroll for 8 weeks. This is an 18-month process. We need structural changes, not Band-Aids of a few weeks. If you're a small business trying to plan for the 18 months, 8 weeks ain't gonna do it. And I don't think the government has got its head around, certainly not the administration, and even Congress has gotten their head around, all right, what are the structural changes we need? You know, starting with universal health coverage for people, starting with a big dose of loan forgiveness for people, coupled with, I think, not just straight loan forgiveness, but you want loan forgiveness with, let's say that once we get over this hump, you pay back slight added onto your tax. So for example, if we were to forgive all education loans, but that doesn't mean you go scot-free. That means if you make, you know, call it over 60,000 or some number, you begin to pay back that loan on your income tax as long as your income is up, so that we can, you know, have solutions that match when the economy comes back. Anyway, I think those are the kinds of structural solutions we need to begin thinking about. We also obviously need to have universal family leave, this idea that, you know, people are working in grocery stores, maybe they're making 15 bucks an hour, but they're risking their lives with no health benefits and no family leave benefits and no sick leave. Come on, that just is so unfair and exploitative of those people. We're all benefiting from them, but they don't have the benefits that, you know, us who can work at home, and, you know, our big problem is how do we figure out Zoom working? That's just not on, it seems to me, in this society. So I think we're going to have to confront the structural changes we need, and I don't really think Washington has gone there, but that's going to be necessary to get us through this period. Much more to discuss, but let's get to your questions.
So that is a little gloomier than my personality would tend to.
Look, I am the optimist. I'm always optimistic, but I don't. We have to be realistic here, because we can't have the right plan to solve this if we keep thinking, oh, we're going to be back at work in, you know, June, or we're going to be back at work in September. It's going to all be normal. I want us to think, and again, I'm like you, Michael. I am like Mr. Optimistic all the time. You know, my kids always say, you know, I've got confidence over competence. So I'm always saying things are going to be better than they are.
So here's a question for you that we talked about a little bit with our guest last week, Zaidrad Al Hussein, and that's about how we should think about balancing, why don't we say rights, in thinking about issues of privacy and surveillance and the public health response to the outbreak. And how do you think we should be balancing those things? Should we be giving the government more authorities to track people, to do cell phone tracing, to do lots of things that we would generally be uncomfortable with? If we do that, how do we roll it back at the end? What are your thoughts on that dilemma?
Yeah. First of all, people, I think, are more than willing to give up lots of rights now if it'll facilitate us getting control of this. And I think that's inevitable. From the public health standpoint, I'll just go back to, I was helped run the H1N1 response when I was in the White House in 2009, 2010. We massively incentivized creating a vaccine, got the vaccine, but the worry was over. During the height of the crisis, everyone would have gotten a vaccine. We ended up with a whole lot of extra vaccine because the moment this passes, people then want to retrench back to normal. And I think the same thing is going to be true of privacy. Happy to give the government lots of data if they can, track, give me some help with the contact tracing, all of that stuff. But, once this crisis is over, I want it back. I don't want them knowing. And so I think we're going to have to, any legislation or thinking about it is going to have to respect that, which is, yes, we'll give you the information now. It probably, that contact tracing stuff should be destroyed every after 45 days, because it's probably not useful after 45 days. And then once we get through this and we can put some designations, there's an effective vaccine, blah, 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 we take that power away. I do think that is going to be the inevitable cycle to this. We are in an emergency. A bigger emergency than I've ever had in my life, a bigger emergency than anyone who wasn't alive in 1918, or maybe World War II, if you want. Maybe it's World War II was the bigger emergency. It's certainly going to be more devastating than the Great Depression. I am pretty sure about that, in part because it happened overnight. I mean, I can't tell you the number of small businesses. Friday they locked down. Monday I had to have a different business model if I was going to live.
Right.
They're all cut back. And so in some ways, I analogize it to an explosion, right? It just descended on us. And there was, there should have been a couple of months of prep, but even a couple of months of prep is not like World War II, where, we had years of prep, right? September 1st, 39, Germany invaded Poland, and Pearl Harbor was in December 41. It's a very different timing, and the damage being done to people is in a different timeline, and the number of deaths is going to be in a different timeline. And I don't think the business as usual or the typical approaches are going to work. I do think, we're just 18 months. I hate to say it. I really hate to say it.
So I now want to turn it over to Karen, who to ask a question.
Thanks, Mike. So we've had some questions coming in about the difference in the European and American response to COVID-19. And I want to pick up where you just left off, which is how do we start reopening our societies? And you recently wrote a piece in the New York Times suggesting June might be the right time point. If we look across Europe, you have one case in Sweden where they have not imposed a lockdown. Then you see countries like Austria and Denmark that have announced concrete plans for starting to open up their societies already next week. You have other countries like Germany that are saying not useful to put a date on this, let's play this through. But you see this tension between safeguarding public health and economic security. And when you look at these examples across the world, tell us how you came down to feeling June is the right timeline, because it also seems that if we look at Asia, we're seeing some countries now struggling with a second wave of infections. So help us understand how you think through this.
That's the best question. It's really the question of the day. So
Good job,
first
Karen.
of all, I mean, I think it's on everyone's mind, and legitimately so. So first of all, we should go back before the article in the New York Times that you're citing. I wrote an article about the roller coaster and what we should anticipate, which is, yes, we'll get through peak one with good social physical distancing and other public health measures. But when we begin to reopen, we're going to have a second peak. It may be not as high, but it's certainly going to be a noticeable peak. And I will just say here for the audience, look at Singapore, right? Singapore did a very, very good initial reaction. Then they eased up. And what happened was in the last month, they've had tenfold increase in the number of cases. And they've recently, on Friday, they closed schools for a month and they closed all the non-essential businesses. Wave 2 or hill 2 in the roller coaster, however you want to describe it. And yes, anyone who opens up is going to have a second wave and needs to be prepared for this subsequent resurgence. And there's going to be multiple resurgences until we get that vaccine. That is part of the inevitable. What you have, in Sweden, you have probably a slightly better situation. First of all, a smaller population. There's rural people. There are a few major cities, good public health infrastructure, good neighborhood contact tracing ability. So they can, probably skate through with minimal closures. They still need to do the physical distancing and other stuff, but they can continue with business. I think in Austria and Denmark, you're going to see a big resurgence. It's too premature. And when I wrote June, not June. I wrote June with caveats. Certain things need to be in place if we're going to do that, and we need to see certain, numbers. So I am more with Germany, which is we've got to follow the data, follow the number of new cases, the hospitalization rate, the death rate, before we make a decision. June was where I thought, given what we're seeing, if we lock down when I said, which was the end of March, you have an 8-week course, you're into early June if you do it all right. And by the way, the early indications from Seattle, San Francisco does seem that physical distancing is able to flatten out this curve pretty effectively. And it may be an 8-week cycle. But what I'm fearful of is we get to the top of the curve, the deaths, the number of cases begins to flatten out, go down even. The number of deaths maybe flattens out and goes down. And then people are like, well, let's, open up. Let's stop the social distancing, stop the face mask, and et cetera. And that's going to be the wrong response. And that's what I'm worried about. But I do think you got to follow the new cases, and you really want to see them go, if not to zero, very, very low. You've got to have very, very good testing in place where people can get tests and we can get the results not in 5, 7, 8, 10 days where they're irrelevant, but you can get them, with the Abbott test and hopefully others coming on where you can get them, within 15 minutes and they're reliable. There's a lot of talk about false positives, false negatives. And you can do some effective contact tracing of people that turn positive, because that also is going to be necessary for people to self-isolate themselves. It would also be important to have serological testing so we have a better sense what the frequency in the population is, which is very likely to be much higher. There's data out of, if you look at what's called influenza-like illnesses, how many people come in with fever, big uptick in Washington State, sort of mid-March, probably suggesting a lot of younger people were getting infected and we weren't testing them we didn't have enough tests, and we thought, unlikely or not seriously ill. And so I think we need a whole infrastructure to really monitor this, to be in place for a safe opening up. And, I'm related to someone who's like, I can't believe we're sacrificing all of the economy for a few 100,000 older people or things like that. It's like that you're not thinking about it in the right way. I will just note their report yesterday, 4 people in grocery stores died, including a 27-year-old 2 at Walmart, 1 at Giant, 1 at Trader Joe's, including a 27-year-old. Now, how are you going to get people to work in grocery stores if the trade-off is $15 an hour and I might die? That you can't open the economy under that condition. It's just not going to work. And so I think we have to be able to do a better job of protecting people, isolating positives. So before we can really, really begin to turn the spigot up. That is the one, and again, I'll just reemphasize it. It's not unheard of. It's not like it never happens, but it's, exceedingly rare for someone under 19, even under 25 to die from this. There are a couple of case reports, but they're so small given the millions of people that no doubt have this, that's probably the safest group for us to begin thinking about allowing to get back to a normal life, which is probably good. Kids need a normal life. And as long as we recognize there's a risk that if they get it, their parents could get it. But I think that's how, parents have to be well aware of that risk and think that it's worth taking. But I think that's where I would look for opening up.
So Zeke, let me, we now have 44 questions in the Q&A, a number that have come through in the chat. So let me turn to a question that's popped up in a number of different variants in the chat.
Yeah.
Which in the Q&A, which is, why don't we say variations of why, oh, why is there not universal testing in the United States? Should we expect that? When do we get, when does this testing thing get addressed at least?
You're not going to have universal testing. No country has universal testing. Just
Should
not.
we?
Universal as in everybody in the population tested? No. I mean, even South Korea, which is touted, highly, does not have universal testing. I mean, they've done less than 1% of their population. Maybe they're up to 1% of the population. They have 50 million people. Maybe they're at 500,000. Maybe they're a little over. But that's 1% of the population. That is not universal testing. What we do need is we do need a community survey, so we know what the prevalence is in a community. That we haven't had, and it's super frustrating, nor do I hear it. Cuomo has suggested that he's doing it, but I haven't heard it. The closest I've heard is they did something similar in Santa Clara, California a while ago and had an 11% of the population there had it, but that's hardly a representative, the right place you would want to do it. So you do need testing, and we need to have a sense of how many people have been asymptomatic and don't have it. That is critically important to understanding the case fatality rate, what the demands on the hospital system are or might be, better understanding of this age distribution, better understanding of the comorbidities, the racial disparities that we're just now beginning to see. So we definitely need that. And we definitely need lots more, and as I point out, rapid testing, so we know and we can tailor our interventions to people. I would say to the audience, just for your own personal benefit, if you've got a fever, you've got a cough, but you're not having difficulty breathing, you should stay at home and self-quarantine. You don't know, the last place you want to be is in a hospital emergency room. Call your local PCP and do a telemedicine visit, but you shouldn't be at the hospital unless you're pretty sick. It's not a place, first of all, you don't want to clog the system thinking about other people, but it's probably not a safe place for you to be if you don't have to be there at the moment, just because of all the chaos, the infection hanging out in the air, etc.
Thanks very much. Karen?
So to pick up on this point that if we're not going to have universal testing, some of the other ideas that are floating around, in the Netherlands, there's talk about group immunity, which you mentioned earlier, that if enough people have gotten it and recovered, you build up this immunity in your society. And you also, Dr. Emanuel, have talked about having a COVID-19 certification system where you actually track who's come through the disease. Tied up in that are some concerns about privacy. And if there's a certification system and I'm one of the millions who've lost my job, are people not going to want to hire me if I don't have that certificate because I may get very sick and it costs the company? So help us understand how we could use a certification system in a constructive way that allows the economy to get back up and running, but doesn't infringe on privacy concerns. Or maybe you can't square that circle.
I'm not sure you're going to, it's very interesting because yesterday, I think, beginning to hear about people who have tested positive and have come through it, now getting some discrimination and people attacking them because, they were dirty, they didn't follow the public health physical distancing recommendation. It's like, that's crazy. A lot of these people got it before any of this physical distancing was put into place and didn't know, or were just exposed from travel that they didn't, before anyone was really sheltering in place. I do think, it's going to be absolutely essential to have a certification system because those people, first of all, they're going to be essential workers. They can't get it and they can't transmit it. And that is a very important class of people to get things going, helping in hospitals, helping testing, helping in nursing homes. And I do think we're not utilizing them. We've recommended a COVID recovery core for precisely this. There are lots of functions out in society that need it. And maybe if we reopen schools, they'll be the best people to be with kids and the most protected. So I don't see there's any other way than having this. People are now calling it a immunity passport. I think it's going to be essential. Will the government have a piece of information about us or someone, whoever's doing the certifying? Yes. Is that going to be necessary to get us through this? Yes. Is that a trade-off we should make? Yes. And I guess I can't worry too much about it. It's like, am I really worried if the government gets my blood pressure? What it does mean is if we have that system, yes, these are going to be preferential workers, but we need more of them, and we're just going to have to put up with that, and we have to support the people who aren't positive in this time, and get them the right kind of supports in terms of benefits, the right kinds of support in terms of unemployment to be able to allow them to live. So I don't know. Maybe you've got a better mechanism, but I can't think of a better mechanism going forward. And given all the jobs we absolutely need to have done, right now, let me flip it around, Karen. We have 60 million Americans who are working and not sheltering in place because their work requires them to be physically present to keep everything going, whether it's the internet, electricity, water, delivering the food, keeping the prescriptions going, cleaning hospitals, keeping the metro and other public transportation going, keeping gas flowing. I mean, just look at what we need to keep the world that we know going, and the fact that we can shelter in place. 60 million people. Now, it would be really good if we could get people who were immune doing those jobs to reduce the risk. I think that's the kind of thing I'm thinking about. There are a lot of places, for example, as I understand it, water purification workers are exceedingly talented. I mean, it's a high-skilled job. There aren't lots of them. They are actually, living separate from their families to keep the water purification and circling in and out. I know a lot of doctors that have now rented apartments separate from their family so as to not infect their family and still be able to function. Lots of things are going to have to be done to combat this that we wouldn't otherwise contemplate.
So, Zeke, a question in the Q&A came through about China, and a country that is further ahead in a way in dealing with this pandemic, but where there are also a lot of questions raised about the data that we get from China, both in terms of their model, response, et cetera. From your perspective, when thinking about the U.S. response, how much should the U.S. be looking to data from China? How do we deal with essentially the quality of data from China issue in formulating public health policy here, or is that irrelevant?
I don't know that it's irrelevant, but now we have data from lots of other places that we can trust better. It tends to be incomplete too, or there are other problems like the underlying demographics of the population are not readily generalizable. Italy has a super old population compared to ours. How generalizable it is, poses challenges. But more reliable data is good. Bad, unreliable data is not good. I would just note our data ain't so hotsy-totsy either. If you go and look at the CDC website and you look for the testing that they've done, and then you look at things you would want, like the race of someone, the hospitalization rate, etc. You wouldn't call it fantastic data that you would do a lot of analyses on. There's a ton of missing data, and we don't have the best. Some local pockets where they're really good public health infrastructure and public health data collection, much better. But I think we need to recognize that, I don't trust a lot of the Chinese data. For example, asymptomatic people who were tested positive, they don't report as a cases. It's like, what are you talking about? That's relevant information for all of us. Their proportion of people going to the hospital may be lower than others because of the demographics, may be higher than others because of other things that are problematic there. But if you look at New Orleans, supposedly something like a quarter of the people with COVID are hospitalized. That's a very high proportion, higher than what was seen in China. So I think, again, we need to look at all the data, but remember there's a lot of incompleteness there. I don't put huge stock on everything in China, but they did have when they finally got serious about this, they were able to lock down the whole province, fly in lots of healthcare workers, do lots of testing, fly in a lot of resources, and that did prove effective, and it gave you this sort of 8-week cycle, which makes perfect epidemiological sense from just what the disease course is and when you pick it up and how infected people are. So that's been useful, and they did share the genetic sequence, and that's been very useful and pivotal. Other stuff, how big their resurgence is, what they're going to have to do for it, I think maybe we may be a little more skeptical of that data.
So I just want to pick up on one thing and then turn it back to Karen. You mentioned New Orleans, and one of the questions that we got from an attendee asked about the disproportionate impact that coronavirus seems to be having on low-income and minority populations, that essentially the disparities that we already have in access to resources, healthcare, et cetera, are playing out in this crisis as well. How, as a society, should we be adapting to that?
So first of all, what we have are preliminary reports, and
Sure.
I think we need I don't want to say ignore the issue until we get solid data, because that would be a mistake, but it would be good to have more solid data. It is very likely the case, and at least the preliminary data does suggest it's true, that existing disparities in access to healthcare and in health status, right, comorbidity or health problems, etc., are being exacerbated by this problem. There's also this suspicion of the medical establishment, and therefore distrust of the public health advice in many communities that exacerbates a problem, social distancing not being adhered to. So I do think we've got to use the existing resources that we have, whether they're faith leaders, community workers, etc., to get the populations aware of what the proper public health measures are and implement them to the extent possible. And I do think that's critically important. We also need to be aware that many of the hospitals that serve minority and low-income communities have been under-resourced. And I do think we're seeing efforts to bolster those hospitals, but it is harder to respond when you're starting out behind the 8 ball without a lot of resources. And in these low income and minority communities, probably higher comorbidities, higher heart disease, higher rates of diabetes, all of which make this illness worse. So it's a problem. And we're unfortunately, we obviously have to try to ameliorate it now with the measures I've mentioned. But going forward, it really does behoove us to, try to get, work harder to eliminate those disparities before they become a problem, and before they become exploited by another massive health problem.
Karen.
I also worry, I will say, this is a sort of slightly orthogonal thought, but one of the things I worry is we're going to be in this, we're going to be shell-shocked by this, we're going to push hard, and then we might forget, and we might say, no problem. We can, that was our big pandemic. We're not going to have another one in our lifetime. We're not going to spend the resources we need to build up the public health infrastructure. You and I know this, the problem's over, we move on. That is unlikely to be a smart solution, as I like to remind people.
That's part of our sunny American optimism, Z.
I just like to remind people how many new novel outbreaks we've had, just over this last decade. H1N1, MERS, this Middle Eastern respiratory syndrome. We've had Zika. We've had 2 cases of Ebola with very large outbreaks in the Congo and in West Africa. And now the coronavirus. Complacency would be a bad mistake, bad mistake. Thinking, well, we've dodged that bullet, or not dodged it, but we've gotten past it in 18 months, and we can ignore this whole area of public health. I think both for the public health community and the business community, this push for efficiency is going to be overtaken by a push for resilience and thinking more about the tail problems, the low probability but high impact problems, and being sure that we have more infrastructure protecting against them. That has to be the lesson of this. And those problems, they're not only infectious. Climate change is obviously one of them, but I do think we need to think more systematically about that, those black swan events.
Karen.
So one of the questions from a member of the audience is near and dear to my heart. What should be the top priorities for transatlantic cooperation in responding to this crisis? And I wanted to draw you out on this because we've seen in the immediate response to the crisis, overwhelmingly national responses.
Yes.
So we've seen ban on medical exports and all kinds of other things. So if you could step back and say what would be most helpful, what are the areas where if the US and Europe were cooperating, is it about allowing the free trade of medical equipment? Should it be that NATO has medical stockpiles going forward? Should it be American and European scientists working together on a vaccine? Maybe they're already doing that. Should there be American and European cooperation on that COVID-19 certification system that you were talking about? And maybe as a footnote to that last point, we've had several people come back and say, how do we know that you can't get COVID-19 a second time? How do we know you have immunity after you've had it once? So can you just speak to that whole set of issues of where cooperation would put us in a better place today?
I think it was Fareed commenting on Sunday morning that, normally in these kind of situations, to bring everyone together and go, it's American leadership through existing institutions, whether it's NATO, the G7, World Bank, IMF, and we haven't been an international leader, and that's a problem. There are many things that would be helpful to do. You've mentioned some of them. Collaborate on the research. Instead of Trump trying to buy a German vaccine manufacturer, the collaboration with some understanding how we're going to share these resources. Everyone has pretty much the same top priority. We have to do all of our healthcare workers first, and then we open it up to the highest risk parts of our population if we get a vaccine. Well, all of us are learning from everyone else. The technology is something that's been shared. The big drug companies, big vaccine manufacturers, they're international companies. They may be headquartered in Switzerland or Germany or New Jersey, but they're international. They've learned from each other. And I do think we need to have collaboration and cooperation. A stockpile that is international could be very, very important, and a novel way of thinking about drawing people together to work together. I think this idea of each country is going to get a new technology to track, to do contact tracing, their own technology on immune certification is absurd, right? I mean, all of us appreciate the fact that there's an ATM system and you can get money internationally. Literally, we take this for granted, and yet we shouldn't take it for granted. That tells you that these cooperations can happen and that they can be quite helpful in reducing the barriers and extra friction in life. And I think that's exactly the kind of thing where if we had a strategic plan at the White House, we would be doing these things much more systematically and reaching out in a much more regular way. And I do think, you know, we are allies, and yes, there is nationalism, and it's going to be inevitable in these kind of circumstances, but they're also leadership, and leadership overcomes those, you know, momentary nationalistic things for the larger good. And if anyone should be interested, it should be the United States, right? We don't have enough N95 masks. We don't have enough ventilators. We don't have enough equipment. We've been turning to the world and send them to us. Well, how can you say that unless you're going to be willing to share your, you know, whatever you have extra of, if it turns out to be a therapeutic or a vaccine? I don't see how we can say those two things simultaneously.
So, Zeke, a lot of people in the Q&A and the chat have raised, you know, something that's been bubbling in the media for a while, which is what role is weather going to play over the summer? And, you know, specifically, you know, what is our best understanding at this point about whether, you know, warm weather will reduce transmission, and how worried are you about the way that might lead to an easing of social distancing policy too quickly?
Well, deal with the first thing. If you know the answer to the weather thing, let me know. I'd love to know. The simple fact is we don't know, and here's the positives and here's the negatives, right? A lot of coronaviruses do have seasonality to them. A lot of, you know, the flu has seasonality to it. So maybe this will have seasonality. That was a big talking point that Trump had about 4 weeks ago. Right. You know, oh, it's going away. You know, we're going to get warm weather. It's going away. Here's the argument against it. Not all coronaviruses have seasonality. And second of all, there's reason to think this one isn't going to be seasonal, at least in season one. And that's for two reasons. First, Australia, Singapore, Israel, Egypt, places that are warm, their temperatures equivalent to our summers now, they're having big outbreaks. Seasonality also seems to be not just the temperature, that's one aspect, but also the number of people who are immune. You know, through the fall, people get fall and winter, people get immune, and then we come into late spring, early summer. You've got a high number of people who are immune, and the R0, it's harder so to transmit. It's not impossible, but the R0 goes down. That's a transmission number, goes down because of immunity, as well as the fact that it survives slightly less well in the warmer weather. Well, when you don't have the immunity in the population, that's not quite at herd immunity, but high, that seasonality may disappear. And, you know, again, going back to influenza of 1918, 1919, you know, it was around in the summer. The first wave was actually over the summer. So I wouldn't bank a lot on it. And, you know, like the oncologist I am, you know, you can't plan. It's definitely going away. If it does go away, we're lucky. Or not go away, it'll just go down. We'll be lucky, but we can't count on luck. That's not a way to win a war, and it's not a way to win an election. It's certainly not a way to, you know, win a public health crisis.
Karen.
So some of our participants rightly said we shouldn't limit the conversation about international cooperation to the US and Europe, and certainly Dr. Emanuel, you didn't in the response to my question. I was thinking of the US and Europe as a core that would lead to broader global cooperation, but I want to connect that to another question we've had, which is how you see the pandemic progressing, for example, on the continent of Africa. And what are the ways that one can try to help countries that are perhaps less prepared to manage a public health emergency because of their underlying health system or because of their economic structures? And how do you think about this spread in parts of the world where we're not seeing the numbers, perhaps because we're not testing and we're not identifying what's happening there? So over to you.
It's assuredly because we're not testing, not because it's not there. So first of all, the advantage, quote unquote, in many of these places is the different age distribution of the population. Many of the sub-Saharan African countries have a age distribution which is skewed down compared to Europe and Asia and the United States. Now that will be beneficial. Some of them, many of them also have large rural populations. So there's dispersion, which will slow things down. I note, I often work in Ethiopia, and in Ethiopia, there's one big city, Addis Ababa, but, basically 90% of the population, more than 90% of the population is in either small towns or completely rural. That'll be fine. Obviously, Nigeria is a completely different situation. You got these mega swarming cities, and that is going to be a problem, right? Really hard to physically distance in Lagos. And I think that is, and their healthcare infrastructures, no way, no how, able to handle this. There's just no proper infrastructure, and they will have a higher mortality rate as a consequence, probably in the, fully in the 1 or 2% range. And I don't know that there's not a acute solution to this underlying problem. It may be that in some of the countries, some of the advantage, and by the way, travel is also much less, cross-border travel, much less. So those are some of the things that'll make it probably slower, and maybe slow enough that the big hits won't happen until we have a vaccine. I have to say that the optimistic scenario here is their advantages hold for a couple of years, and the heat and activate or the inactive viral vaccines that are being developed are, we're able to generate billions of doses, and they will get, we have a lot of capacity for producing those things, and they will be able to get them relatively quickly. But, like everything else, it's a very big worry. I would say that maybe even more worrisome than sub-Saharan Africa is places like Latin America, where the age distribution is older. They do have some healthcare infrastructure, but nowhere near enough. And we already know that, it's looking more like a Black Plague kind of situation, bodies literally piled up in the street, as opposed to the kind of response we would hope to have.
So, Zeke, I want to move from the global to the local. You just spoke about the challenges in Latin America and in Africa. How are we doing in Philadelphia? How are things going in DC? How do you think our cities are handling this? How prepared? I mean, we're not neither place is in the situation that New York is in right now, but so how are we doing?
So far, as I say, DC seems to be doing okay. There actually is in DC a daily blog where you can see the age of the people who are getting it and their sex. And it turns out we are heavily young. DC is a younger city. So you see a lot of cases in the 30s, probably will, not all of them are going to do well, but a large number of them are going to do well and probably not need hospital infrastructure. And as I mentioned, I think before we came on, we're probably pretty well. Last I looked, which was a few days ago, there were something like 150 or 160 ventilators being used, and there were like 405 available in the city. So probably DC is going to, and physical distancing, DC's been number one in adopting it. Relatively well-off, well-educated population, and you see the physical distancing really present in the city. Philadelphia, so far the hospitals, they have a lot of cases, but they're not overwhelmed, I would say, and they are able to manage the cases. There's a lot, I think, positively, a lot of research going on. Some of the world's best people on hyperimmune responses are in Philadelphia, and I know I've talked to them, doing a lot of thinking and research on this. But I do worry that the physical distancing hasn't been as great. The closing of the schools may be a little later than one would have liked. But I do think also, we've learned how to skate through. That you got to have two worries. Worry number one is New Jersey's not far. And New Jersey is, if the epicenter is moving south from New York to New Jersey, I can follow the highway too. And that, you have to worry about that. It's not just, going to stay up there for all sorts of reasons. I do think it gives better time to plan, more time to plan. And frankly, we do have a very, very good people at the top who are, very, very, they know how to run strategic plans. They know how to organize resources. So I don't want to be overly optimistic, but I do think that that there's a good sense of that. The other thing I would say, I don't see this virus coming up, as it were, from Maryland and Delaware into Philadelphia, because Maryland, Larry Hogan was Republican governor. One of the, I think he was the second governor to close down schools. They have done a very good job of getting on top of this early on. We do have one problem of a nursing home in Maryland that almost essentially every patient, about 100 patients, has got it. They weren't using PPE. It's quite clear that someone was going from patient to patient, right? And real disaster. It's going to be a disaster there. But I think statewide, going to be much better than, for example, Louisiana. So I think they're probably relatively contained south of Philadelphia. Last I looked, there was some worry about Pittsburgh coming up, and I have to say I don't know what the ins and outs of the Pittsburgh situation are. They do have a couple of good health, big health and well-managed health systems there, and hopefully they'll be able to respond. I would say, finally, the virus is just changing all of the way we manage healthcare, and structurally, it is having a financial hit on the Penn health system because you've got a lot of patients in the intensive care unit, which is very expensive. Surgery procedures, which is relatively profitable, aren't having. So I think how this impacts the finances and how the bailouts all work is obviously a concern, and we've got fine people looking after that. But I think this is going to be something we're all going to have to think about. I'm now thinking about, well, what's the post-COVID healthcare? How is COVID going to permanently change the healthcare system?
Sure. Well, Zeke, we are about out of time here. So why don't maybe we can have you back for another check-in, basically.
2021, absolutely, Michael.
About how we're doing. And for now, I just want to say thank you for joining us today for our virtual The World Today. Next week at 12 p.m., we'll do another virtual The World Today focused on U.S.-China relations. In an era of coronavirus, it's going to be an unbelievable event, and I hope everybody signs in. And now I want to turn it over to our partner at the German Marshall Fund, Karen Donfried, to close us out.
Just a huge thank you to you, Mike. Dr. Emanuel, thank you for this fabulously thoughtful and illuminating presentation. I know I benefited, and I also know each of us has agency in fighting this for all the reasons you said. So thank you for delivering a sobering message, but in a way that also is empowering in terms of deepening our knowledge. Thank you.
Thank you very much for hosting both Michael and Karen, and it's been illuminating to me, and great question, really the best questions I've had, because they go right to the heart of the things we don't know, but the things we have to plan and think about and strategize for. I only wish that the government was doing more of this long-range thinking rather than worrying about the next 30 days.
Well, on that sobering note, I hope everybody has a great day and stays safe, well supplied, and healthy.
Bye-bye.
Bye, everybody.